Hi everyone, and welcome to the ESG webinar, Green Endoscopy from Wishful Thinking to Implementing in Practice. And why are we here today? We are here today because winter is no winter anymore. Summer looks like a never-ending heat wave, at least in Madrid, Spain, and GI endoscopy may have something to do with this climate crisis. My name is Enrique Rodríguez. I work at the Ramón y Cajal University Hospital in Madrid, and I'm the chair of the ESG Green Endoscopy Working Group. 2 or 3 years ago, nobody seemed to care about the environmental impact of GI endoscopy. That's why ESG decided to create this working group. With this working group, we aim to raise awareness of the ecological footprint of GI endoscopy and to provide guidance to reduce its environmental impact. And what have we achieved so far? Last year, we published, together with Gina, the first position statement from a scientific society, GI Endoscopy Scientific Society, in order to help the physicians to reduce their environmental impact in their clinical activity. We also conducted 2 sessions during ESG Day 2022 in Prague, and more to come in Dublin. And we had 2 webinars. We have also made a huge effort to make ESG Days 2023 greener, and we have more projects coming soon. Before starting the first lecture, I would like to introduce my co-moderator, Mathieu Pioche. Mathieu Pioche is a gastroenterologist and endoscopist, professor in Lyon University. He's personally and professionally concerned about climate change, and he's a member of the ESG Green Endoscopy Working Group, and he's also involved in several sustainability projects in the French Digestive Endoscopy Society. We have a great panel of experts today. Our first speaker is Heiko Pohl. Heiko Pohl is professor of medicine at Dartmouth JCL School of Medicine in Hanover, New Hampshire, and he's the director of endoscopy at the Veteran Medical Center in Vermont. His main interests are quality of endoscopy related to colorectal cancer screening and Barrett's esophagus. He's also the leader of the USGI Multi-Society Task Force on Climate Change and the American Society for Gastrointestinal Endoscopy Task Force on Sustainable Endoscopy. Heiko, thank you very much for accepting your invitation. It's an honor to have you here. Please go ahead.
Thanks, Enrique and Mathieu, for inviting me for this to talk on this important topic. So here are my conflicts of interest or competing interests. So why are we talking about green endoscopy? So I'm trying to give like the introductory perspective on what really is the problem on this topic and how can green endoscopy a solution or part of the solution for the problem. And jumping right in, what really is the problem? The short answer is probably us, human beings. We have shaped the environment over the past 200 years during the industrial age as never humans have done before. No matter where we go on the earth, on the planet, there's probably always somewhere a trace of our being and our working, our influence on the environment. Therefore, we call this the Anthropocene. Now, over the past several decades, we increasingly notice that the environment gives it back to us in some ways, that we feel through extreme weather events and other things, how we have affected the environment and how this is affecting us. Now, I know climate change is in the center of public discourse, but I want to point out a couple of other facts. This paper was published in Nature a couple of years ago, and it shows that human-made mass has exceeded all living biomass in 2020. I think that's a shocking number. And if you look at the details on the right upper side, human-made mass of plastic doubled the living biomass. So a lot of plastic that we are producing. The other thing I want to point out is the concept of planetary boundaries. So it's not really about climate change. So we have several domains that we would consider planetary boundaries beyond which, when we cross them, living on this planet as a human race is not sustainable. And as you can see, the climate change, we are in the yellow zone, meaning we can still do something to prevent the worst from happening. While biodiversity and chemical flows, and particularly nitrogen flows, we are already in the red zone. So we surpassed the boundaries already. So of course, all of these components are complex and related and probably exponentiating each other in their effects, but it's important to point out it's about the environmental impact, and climate change is just but one aspect of that. So when we talk about climate change, I think most of you have seen that curve of carbon dioxide has reached a concentration as we have not seen it in approximately 2 million years. And it is said that the ice caps have not been sustainable at this concentration of carbon dioxide. So some may say it's just a matter of time until all the ice melts. And of course, we've seen all the pictures again and again on disasters related to climate change and a changing environment. Now, with that, we see a change in disease pattern. So climate change does affect health, and the Lancet Countdown on Health and Climate has said that climate change is the greatest global health threat facing the world in the 21st century. And of course, our healthcare system also is affected by this, because we see a change in disease pattern, have to be ready for emergency situations as floods or hurricanes or wildfires. Now, we can spend a lot of time on this. I just want to point out that the environmental changes intensify inequalities. Those that have had the least impact on changing the environment are the ones who suffer the most. Now, what has been striking to me that by providing care and trying to help our patients, we actually contribute to global warming. The healthcare system itself worldwide contributes 4.4% of all greenhouse gas emissions. In the US, it's 8.5%. In Europe, it's about 5%. And if healthcare were a country, it would be the 5th largest greenhouse gas emitter. Just imagine that. A country that could have had a seat at the table when discussing about reduction in greenhouse gases. So it's really important that we do something about that. Now, there's 2 general approaches to do something about that whole situation. Adaptation is one, building resilience in the communities and individual to adapt to the changing climate, and also healthcare resilience. But on our end, we're trying also to change to a sustainable healthcare system. In other words, to trying to mitigate our impact on the environment and climate change and reducing greenhouse gas emissions. The good news, there are a lot of good news, apart from the initiatives that Enrique was mentioning earlier on a national and international level. And I think the UK is really leading this effort with a commitment to a net zero path by 2045. Many countries have committed to a net zero healthcare system by 2050, including the United States, with respect to their federal healthcare system just recently, so which is very encouraging. Just an example, in the United States, the Department of Health and Human Services, the healthcare ministry, so to say, put out a pledge letter to healthcare institutions to commit to a net zero path by 2050, and more than 100 healthcare institutions have committed to that already, which is fantastic. Just on a societal level, there are many initiatives within Europe, but also in the US. So we have this ESG in our position statement, the British Society Gastroenterology statement. We have worked in the US on a 4-society most strategic plan. It's a 5-year plan that addresses different domains in GI practice towards an environmental sustainable practice. So we hope to share the first initiatives or the ideas here with this webinar. So how can green endoscopy be part of the solution? If you think about what can endoscopy do to get to a 50% carbon dioxide reduction by 2030 and to a net zero endoscopy by 2050. So those are goals that we could set, and I think they are achievable. Of course, we have to understand where the carbon footprint is coming from. And there are those scope 2, 1, 2, 3 emissions. 1 is direct emissions from burning fuel and anesthetic gases. 2 is indirect emissions from the electricity, ventilation, heating, and so forth. The biggest contribution is actually coming from the supply chain, which is mostly consisting of the disposables, the supplies and equipment we need we use in endoscopy. So And therefore endoscopy is just the ideal target to do something about it. So here you can see just at the end of a 1-week waste audit, this is just part of the waste that was produced in an advanced endoscopy room in our unit. We have a lot of disposable supplies. As you may have heard, endoscopy is the 3rd largest generator of medical waste among departments in the hospital. And when we did our audit, we calculated that per procedure, we produce about 2.1 kilogram of waste. That's not counting for reprocessing waste, and would pile up waste to 1 meter of 117 soccer fields. So it's quite a large amount of waste. Most of this is municipal waste ending in landfill, but there's also a lot of biohazard waste or regulated waste, and minor proportions being recycled. It turns out that a lot of this biohazard waste is kind of misplaced, and I think there's a big potential of having appropriate waste segregation in terms of cost reduction and environmental savings. We also have to make sure that we're really very mindful about taking on new disposable devices. And here about disposable endoscopes. You've all heard about these 2 disposable duodenoscopes. If we were to switch to disposable endoscopes, the net waste would increase by 40%, huge amount. Now, there's this recent study in GI that looked at disposable duodenoscopes, and not only would the carbon footprint increase by at least 23-fold, they also did a health impact analysis, and the potential initial gains from infection control would be minimized by later on health impacts related to environmental impact. So reusable duodenoscope with a cap had a lower human health impact than single-use disposable, here lower in upper bounds. All right, how does endoscopy impact the environment? Of course, we first think about what we do with our instruments and our accessories and the medications, but there's really more. The waste we produce, how we organize the endoscopy, the infrastructure that we work in, the travel of the patients and the staff, and also related to education and research. And in all of these domains, we can make a difference. Is it the right procedure? You know, do we have to do it? Is it low value, high value procedure? Is it the right intervention? Should we use a snare or a forceps at the very basic level? Is it the right equipment to use? On waste, I think we will hear more about use, reuse, recycle. Organization. There is something about green efficiency. So can we make our organization within the unit as efficient as possible and thereby have a lower impact? Green purchasing, choosing those equipments that have a lower impact. And green building, green energy, that is clear. Of course, we at the basis have little impact on that, but we can at least call for it. Travel, stay local, potential for virtual work days or work hours, difficult if you're an endoscopist. And then integrate the green idea into education and research. A lot more to say about all of these domains, but in general, we also want to think about what are green quality metrics. How can we bring sustainability as a domain into quality? And then we want to advocate for all of these, not just with our peers and among society, but also to industry and policymakers. So how can we and I affect change? I just want to point out that no matter what level you work on, in your unit, in the hospital, regional, international, it's always you as the single human being who can affect change. Because behind all of this is a human being that has an influence on their peers. So I just want to encourage you, even if it seems like a small thing that you might do, it's worthwhile, it's valuable. I'm going to skip that in time for time interest. I want to just point out before coming to a close, it's important that you not just do it alone in your unit. You should assemble a team, choose a task, have a coordinated effort, identifying the situation and identify alternatives and implement them. And it's key that all have to be in. So it has to be a unit effort. Finally, I want to say that I believe that the climate crisis is also, and maybe above all, the crisis of our own relationship to ourselves and to nature. We have made nature our servant, but yet we are part of it. We are a component of nature. And perhaps in GI, we see that. We know that the microbiome is part of us. So where does our human being stops and where does the environment start, the outside? It's really, we are embedded within nature. And I think rediscovering it and owning it might help on the path towards sustainable living. And I want to close with some quotes from Mahatma Gandhi. The difference between what we do and what we are capable of doing would suffice to solve most of the world's problem and be the change that you wish to see in the world. Thank you.
Thank you so much, Heiko. We have no question for the moment, so I will begin the discussion, but please feel free to ask, to debate. This is the aim of this session. We are a very large producer of waste, of use for energy, for water. We encourage our patients to deal with waste that are going to the toilets, like the capsule, for example. The task seems very, very big. What is your advice to begin with green endoscopy in your unit? Because it seems so large that I think people are sometimes lost in how to change something at the beginning and introduce themselves in this very long way of changing our endoscopy.
Thank you, Mathieu. I think it's a key question, and the task seems overwhelming and at times maybe depressing, and you might just want to hide and say, oh my God, what can we do? But I think, well, on the personal level, what is the right thing to do? You know, can you keep throwing away recyclable plastic? Should we continue to order things that increase the waste? So on a unit level, I think it's important that you start with one task. You start to build a team. You communicate with people who are enthusiastic about it, and you choose one task that you think you can accomplish.
And how it
something
impacts,
simple, like for instance, waste segregation.
How it impacts
like the
in
waste
quality of life.
medically regulated doesn't have to be in the, not all of this has to be in the red bin. So and each of the units are different in terms of what they can accomplish. I mean, other potentials are, for instance, gowns, reusable gowns. So I think there's the water issue is an issue. The water containers are an issue. You know, could we have biodegradable and compostable water containers that we use? And then performing endoscopies, it's important for us to consider, okay, do I really need this extra equipment? Is that really needed? Like, do I need, with this forceps, to take off a polyp, or just do a snare and then I only have one instrument? I think there is small incremental change that we can make that eventually will have a bigger impact.
Thank you so much. We have some points. One of the questions is about single-use scopes. How to deal with the industry who is actively acting for imposition of single-use scopes. How can we work collectively to generate the evidence and restrict the use of a single scope to small areas where it could be really useful and change the paradigm of endoscopy? What is your advice about this?
I think we have to be really careful about adopting such a big change universally. There may be rule in some selected circumstances, but we have now a couple of papers that suggest not only that we increase the waste, but also that the environmental impact is worse and that eventual health outcomes are worse. So the idea that we reduce infection and thereby make an impact on health is probably not correct. And then I think we should hold companies accountable and ask them really, what do you do? What do you do about this increased disposal of waste? And not stop when they say it's recycled, because there are details to it which is just not quite true that's being recycled, at least in the United States. So I think there has to be transparency, and then we should also hold industry accountable, at least getting conversations about their own interest towards sustainability and how this would align with their own interest towards it. And I know companies trying to go that path, but is it really aligned with that interest? So it's an open conversation. It's also not something to, you know, we all have different interests, right? Companies have their own interests, and I think there has to be an open conversation how we can work together. I don't think that any human being wants to have nature destroyed or have their children or grandchildren not be able to walk through the woods that are healthy. You know, so I think we all share this value, and at that level we can connect and see if we can find common ground and make changes.
Last question before introducing Joao. There is a question about how to do good analysis of the life cycle. It's true that we are quite beginners in the evaluation of our environmental impacts, but thanks to your publication and some of the other publications that are coming, we should become professional of the assessment of our environmental impact in endoscopy. What is your advice to improve our quality research parameters, also for ecological parameters?
Yeah, I think I mean, I'm trying to really learn it. I'm actually going to participate in a boot camp coming next week. But I don't think it's really our task as gastroenterologists. I think our expertise is in clinical practice. So I want to understand it better. But they're experts doing this, and luckily there seems to be an increasing interest. When we do life cycle analysis, I mean, we usually talk about value in terms of effectiveness over cost, right? How much does it cost to save one quality adjusted life year? We have to start taking the environmental cost into account and the social aspects too. So learning how to combine those three vectors of efficiency, like quality of care, cost, like the financial economical aspect, and the environment. And I think we have to kind of think about more in those kind of three vectors. And so far we have only thought about in two vectors, and the social aspect is also part of that. So and that's like a change in how we think about it and how we present our research data as well. It's a longer topic, but yeah, it's important to learn more about that.
Thank you very much again. Can you answer to some of the questions in the Q&A? And I introduced Joao Neves, who is a fourth-year gastroenterology resident at the Algarve University Hospital in Portimao, Portugal. Really interested and involved in sustainability in endoscopy and IBD, and he is an active member of the ESG working group for Green Endoscopy, and also in the Portuguese Society and Portuguese IBD study group. Joao, thank you very much.
Thank you very much for the kind introduction, Mathieu. I would also like to thank ESG for this invitation. It is in fact really an honor to share this webinar with such renowned experts on the field of green endoscopy. And today I'm bringing you some of my practical tips of how you can make your department greener. These are my disclosures. And the first thing that you need to know is that I think it is important for us to know where we actually stand. It is undeniable that climate change is a reality, but evidence about the true environmental impact of endoscopy is unfortunately still scarce. And it was this lack of clear data that has led several endoscopic societies to release their position statements on sustainable endoscopy. But the true question is, where can we go from the wishful thinking to implementing in practice? And I think these two pictures from the ESG and BSG position statements perfectly summarize our fields of action. And the main message I would like to convey is that we should not focus solely on endoscopy rooms, because sustainable endoscopy begins, but also ends outside of our endoscopy rooms. And how can we act? First, I think we should always follow the 5R principles of sustainability to guide our path, which are reduce, reuse, recycle, rethink, and research. And secondly, and most importantly, we should always remember to take small steps and begin with achievable goals. And we should start off our journey towards greener endoscopy before even stepping into the endoscopy room by maximizing appropriateness. This includes reducing unnecessary endoscopic procedures. We know as a fact that up to 56% of upper GI referrals and up to 52% of colonoscopies are deemed inappropriate. But we have ways to lessen this burden, such as the enhancement of department vetting procedures, implementation of periodic updates for adequate endoscopy performance, establishment of regular educational activities to endoscopy practitioners, and lastly, but most importantly, we should always pursue guideline-supported recommendation pathways and look for non-endoscopic diagnostic alternatives. And I would like to focus your attention on this last practical tip. As for example, the Baveno 7 already establishes that patients without clinically significant portal hypertension do not require endoscopic assessment of varices. And we have other clinical conditions such as gastric ulcers or celiac disease that may also not require endoscopic surveillance. We should also try to prioritize as much as possible the use of non-endoscopic diagnostic alternatives, such as the fecal calprotectin, which you can use for patients with low likelihood of having IBD. And we also have another few strategies, although some of them are not fully validated, which include the FIT, the cytosponge for risk stratification of paresophagus, and also the capsule endoscopy and CT colonography for bowel cancer screening. It is also extremely important to have a structural remodeling of our units, with establishment of energy reduction strategies, which play a massive role in reducing the environmental impact of endoscopy. For example, we should replace inefficient bulbs with LEDs and motion sensors, as this will grant us a reduction of about 60% in greenhouse gas emissions and lighting costs. We should also try to establish power-down initiatives for all inactive electronic devices within our departments, prioritize the use of renewable energies, and reduce as much as possible heating, ventilation, and air conditioning whenever our endoscopy rooms are not being used. And we should also go digital, turn our endoscopy units as digital as possible, as this will allow us to reduce paper-related burden, namely documents such as information leaflets, printed informed consents, and also endoscopy reports. These may be replaced with interactive test message-based systems for appointment scheduling, for example, but also QR codes. But we have to be aware of digital divide. Although up to 70% of patients are familiarized with these technologies, we still have a few that don't, so we should save a few double-sided printed copies, especially on recycled paper, for patients who still require a paper format. Another impactful measure is to increase environmentally preferable purchasing. This is buying a product that has been created and supplied with minimal environmental impact when compared with competing products that serve the exact same purpose. This includes consumables that are made from recycled materials, sustainably sourced and/or recyclable at end of use. It is also important to have a rational use of accessories and adequate technique selection, as this will allow us to reduce inadvertent use of material. For example, we can reduce the use of endoscopic accessories by combining both upper and lower GI endoscopies whenever appropriate. This will allow us to reduce personal protective equipment and single-use consumables disposal, reduce water and energy consumption, and will ultimately grant us the possibility of reusing some of our accessories between procedures. We must also be able to carefully assess and anticipate what will be required for each procedure. We all know that due to the risk of cross-contamination and patient safety concerns, single-use accessories have gained a lot of terrain over the past 2 decades. However, this has also led to a dramatic increase of net waste. Therefore, we must aim to prevent excess and inadvertent use of accessories by training not only endoscopists, but also the remaining staff on proper pre-procedure planning. Passing on to waste management and starting with personal protective equipment, we all know that its use has largely increased within endoscopy units, especially in the last couple of years due to the pandemic. They now represent between 8 to 35% of overall endoscopic waste. We have some alternatives, such as the use of reusable gowns, which will allow us to reduce the waste carbon footprint by around 66%. It is also possible to recycle some of these gowns by turning them into fuel by pyrolysis or by turning them into blocks of plastic. And Although waste represents a minor proportion of the endoscopy carbon footprint, strategies to reduce, reuse, and recycle endoscopic waste are still considered easy wins due to their easiness of implementation. However, most endoscopy staff still does not know how to adequately categorize or dispose of waste. It is thought that by training endoscopists on a proper waste management to achieve a target regulated medical waste percentage is the measure which will have the most significant impact on waste reduction. Unfortunately, we also face the harsh truth that most endoscopy suites still lack recycling bins. And if we placed labeled and accessible recycling bins in all endoscopy units, we would be able to reduce 2,700 tons of endoscopic plastic waste. And in order to measure the impact of adequate waste segregation, our group conducted an interventional study on endoscopy waste management, where we assessed and compared the waste carbon footprints and waste processing expenses generated by endoscopic procedures before and after reorganizing our endoscopy unit to reduce and recycle endoscopic waste. And after an initial audit, we conducted an intervention, which consisted on the presentation of the retrieved data with seminars regarding waste handling, segregation, and disposal in the endoscopy unit. Additionally, we acquired and placed recycling bins within the endoscopy rooms and relocated some of the pre-existent landfilled and regulated medical waste bins as depicted in the picture on the right, where we basically removed one of the regulated medical waste bins from inside the room. We allocated a new landfilled waste bin outside of the room, especially for personal protective equipment, which was not fully contaminated. And we also included one recycling bin for paper and plastic inside of each. With this study, what I want to show you is that whenever performed correctly, adequate waste handling and segregation may have a significant impact on the waste carbon footprint and waste processing expenses generated by endoscopy. We also demonstrated that this can be achieved without interfering with overall endoscopic productivity or daily work routine of the staff. However, raising awareness of the staff is key to ensure adequate waste management. It's my personal opinion that each unit should try and elect a green endoscopy leader and some champions. These need to be motivated and resilient people responsible for staff training, for leading interventions, for conducting regular audits and briefings, and also for reviewing existing practice in order to identify areas of improvement. Carrying on to decontamination and beginning with endoscope reprocessing. It's a field that requires our most thoughtful attention. In light of some publications on the development of infections related to inadequate reprocessing, industry has used this as a sort of a motto to implement the use of single-use endoscopes. Although we know that endoscope reprocessing is a resource-heavy procedure, it has been demonstrated that single-use endoscopes increase the net waste mass per endoscopic procedure by 25% and generate 4 times more waste to accomplish the same number of procedures compared to reusable endoscopes. However, we still have some strategies we can use to reduce the impact of endoscope decontamination, such as installing double basin wash machines with both booths running simultaneously, as this will lead to a 25% decrease in energy use. The use of sterile water is still a rather controversial issue during endoscopy. Current guidelines and endoscope manufacturers still advocate its use for purposes of decontamination and through auxiliary water jet channels. But there are some ways we can use to reduce the carbon footprint, especially related with single-use plastic bottles, such as reusing procedures leftover sterile water for bedside cleaning. We can also use some of the tap water for manual flushes through the working channel, and also use final rinse water as an alternative for automated flushing systems. Coming on to my last slide regarding tips. We have telemedicine. Is this helpful? I believe it can be a helpful tool to reduce post-endoscopy face-to-face appointments, as it will allow us to reduce waiting times, reduce also greenhouse gas emissions, particularly related to traveling. However, we have to be careful selecting our patients in order to avoid some of the health inequalities. Coming on to my conclusion, the road towards sustainable endoscopy is very, very much filled with ups and downs and challenges in and outside of the endoscopy room. My personal advice is start off with low cost and easy measures to implement, the so-called easy wins or the low-hanging fruit. These include correct waste segregation and implementation of recycling streams within your units, reduction of paper use, establishment of energy saving strategies. And always remember, sustainable endoscopy requires patience, requires resilience, because great things are not done by impulse, but by a series of small things brought together. Thank you very much.
Thank you very much, Joao. Excellent talk. We have time for discussion. Feel free to ask whatever you want in the chat. There is a question from before, but maybe you are the right person to answer, Joao, because you made a huge effort in your department. I will ask one philosophical and one practical. The practical one, how many bins do we need in the endoscopy unit? Because we need to recycle, but we need to separate from infectious waste. So how many bins do you have in your unit?
So basically, after implementing the recycling strategy, we have one landfill bin inside the endoscopy room, one regulated medical waste bin. We have one for plastic, one for paper, and one for needles and that sort of medication that you need to use. That's what we have inside. And I think that's at least the basics that you should have inside of every endoscopy room, because what we use in our daily endoscopies is basically paper or plastic. So if you guarantee that you have at least those two recycling bins inside your unit, that's a good start.
Okay, thank you very much. And also, you started in your department. I would like to ask, are people still motivated? And how do you keep people motivated? You mentioned the Green Endoscopy champion. Are you doing regular meetings with your team? What are you doing in Portugal?
So basically, the most funny thing about raising awareness of the staff is that I began that as a Green Endoscopy champion in my unit. I took along a colleague of mine as well. And we had some sort of meetings within the staff, always raising awareness, telling them that you're not putting that on the right recycling bin, you should use less paper whatsoever. But once we started lowering off our surveillance, they began being the surveillance ones. So sometimes I have nurses that come to me and tell me, oh, I've just told my colleague that he shouldn't be doing this, he should be separating paper from plastic. So I think it's some sort of a snowball that starts building inside your unit. So I think you just have to start it, and once you start it and implement it, the rest comes along naturally.
Okay, and we have another good question from Ricard Jurawan. Can you comment on histology pots? Should they be smaller, strict, for example, multiple polyps in one pot? Have you implemented any change regarding biopsies and histology pots?
Yes, that will come along in the next presentation. But what I think it's truly important is that we have strict biopsy protocols within your units. We should know what we need to biopsy, what needs to go into a separate container or not, or if we can mix them all together. So it's some sort of a rule that you should establish in your unit. If you do a certain procedure that requires biopsies, know what you'll be doing and the number of pods that you need to use in that procedure.
Okay, thank you very much, Joao. Actually, the next speaker is going to talk about biopsies and polypectomies. Biopsies and polypectomies are the most common procedures for GI endoscopies. Thank you, Robin, for being here with us. Robin is a specialist registered in gastroenterology and research fellow at St. Mark's and King's College Hospital in London, and he's undertaking a research fellowship in sustainable endoscopy. I'm very happy that there is a research fellowship in sustainable endoscopy. Probably you are one of the pioneers, Robin. So thank you. Please go ahead and tell us how to make our biopsies and polypectomies greener.
Thank you very much, Enrique. How have I got control of it? So I have no conflicts of interest to declare for this talk. Over the next 10 minutes or so, I'm going to share what we do know about the environmental footprint related to GI biopsies and suggest some possible mitigation strategies. And then I'm going to move on to share what we perhaps don't know about the environmental footprint of the accessories we use during endoscopy, and maybe introduce some talking points with regard to the mitigation strategies for our intervention. Heiko briefly touched on this earlier with a question about life cycle analysis or life cycle assessment. And over the last 20 years or so, there's been an increase in the interest in this area of work. And this is a graph showing that the number of studies that have been published, which has sought to quantify the environmental impact of what we do, has increased over time. And there are different methodologies used to try and quantify the environmental impact of what we do. Some of those are economic analyses to look at healthcare at a system level, be that the US or the UK or European health systems, and also more granular assessments of the products that we use during endoscopy, during medical care, or care pathways we use, such as dialysis. And one such publication actually pertains to the processing of GI biopsies. And this group of authors are some of the main authors for these type of studies and this type of work. And they published a couple of years ago this paper where they've looked at the environmental impact of processing of GI biopsies in a busy academic laboratory in America. And they've looked at the greenhouse gas emissions associated with this process throughout its whole life cycle. And what this essentially involves is carefully mapping out every step of the process and carefully cataloging all of the energy inputs and outputs that take place along this process, be that the reagents that are used, the products that are single use or reusable products, the travel of the staff involved, or the energy that's used in the building, and also the way that all of these products are disposed of. This inventory of all these items and processes are then mapped against databases which hold emissions factors for different products and materials. And with that, you could develop a picture of the carbon footprint of the process. And what they're doing when they refer to a life cycle assessment is they're looking at the emissions related to this process, right going back to the extraction of raw materials through to the manufacturing process, the shipping, the sterilization, the use, and also the disposal. And what the team found is that although for each individual biopsy that's sent, the carbon emissions are relatively modest, when you scale this up across, for instance, the whole of the United States, this is equivalent to adding another 3,500 passenger cars to the road each year. And that the carbon hotspots, the areas that are most contributory to this carbon footprint, are related to the production of the supplies that are used during the processing step. And that's the scope 3 emissions that Heiko was referring to earlier. But perhaps one of the important take-home points here is that there is no economy of scale when we send our biopsy pots off with regard to the environmental footprint. So they looked at two possible scenarios when you take a group of biopsies, sending them all in one pot versus sending in 3 jars, and there's almost a linear increase in the carbon dioxide emissions that are generated during the increase in the number of pots that are sent. So the question is, what as we as endoscopists, what can we do to try and safely and appropriately reduce the number of pots that are sent off for histological analysis? Well, perhaps most obviously is to ensure that we actually need to send them in the first place. And there are a number of studies that show that we are perhaps overzealous with our biopsy taking. This retrospective study suggesting that in those patients who have a normal upper GI endoscopy, over 90% of the biopsies that were sent did not alter management. Luckily, for junior endoscopists like myself, the ESG have published some guidelines for GI biopsy taking in recent years to help us guide appropriacy and indications for biopsy taking. And it probably is true that less experienced endoscopists are more likely to send off biopsies inappropriately, as we have less confidence in being aware when it will change management or not. in terms of the upper GI tract, there are already quite well established routes for non-histological diagnosis, be that test and treat for H. pylori using stool antigen or digital photo documentation of the ileum for completion of colonoscopy, and then more recent debate regarding a non-biopsy approach for diagnosis of celiac disease using serology, and the minimally invasive techniques such as cytosponge may well reduce the biopsy burden for surveillance of Barrett's esophagus. In the lower GI tract, the point of discussion probably most revolves around how we handle diminutive colorectal polyps, which account for about 60% of the polyps that we detect. And we know that they harbor a low risk of advanced pathology. There are strategies that have been suggested and are taken up to varying degrees to use optical diagnosis as opposed to histological analysis with these polyps. So the diagnose and leave and the resect and discard strategy are both broadly supported by the most recent ESGE update, but it is recognized that there is variation in the confidence and performance of endoscopists with regard to the optical diagnosis of polyps, and therefore there needs to be a good structure of training and audit and performance monitoring in process. It is recognized that this has not been taken up universally by any means, and that may be in part due to the varying confidence in endoscopists of not missing advanced pathology, and also some other incentives that may be related to the remuneration of histopathology practice. There's ongoing questions about the role that computer-assisted diagnostics will have in polyp characterization and what effect that will have in the burden of histopathology that's sent, and also in the future whether there may be more widespread use of live teleendoscopy for expert opinion. But if we do have to send biopsies off for histology, what's the best way to send them? Well, some 28 years ago, Andy Veach, who is now the president of the BSG, was one of the first to add to the literature and suggest sending biopsies on an acetate strip, which could then be sent in a single pot. And if they're orientated correctly, they can be cross-correlated with the endoscopy report to ensure that the location is clear. And it was noted in this paper back then that this is economical in time and materials, and we would now argue also from an environmental point of view. And more recently, a group from West London have done a retrospective study of all the biopsies that were sent in their hospital trust. And they modeled what the scale of the impact would be if small polyps less than 10 millimeters were combined into a pot on a segmental basis by hemicolon or the whole colon. And they looked at over 5,000 polyps over the course of the year. And they showed firstly that it was true that in these small polyps, the rate of advanced histology was very low. So they found only 0.1% of them was found to have cancer in these small polyps, and 0.2% high-grade dysplasia. But they also tried to demonstrate the scale of the environmental impact. And if they collected all small polyps in a single pot, this would, from their hospital trust, result in a saving of around 400 kilos of carbon dioxide equivalent, or driving nearly 1,000 miles in a car. And if this were adopted nationwide in the UK, this may be 100-fold higher than this. More simply and more recently, I must thank Prof. Seb Shadji for this, who sent me this just earlier today. And I think it pertained to a question that's just being asked up in Hull at the moment. They are looking at using smaller biopsy pots. So these look like they're even smaller than half the size, which would obviously have environmental impact implications in terms of the plastic manufacture, transport and storage. But if they can do the same job, then that would be an interesting intervention. It sounds like the pathology department there are welcoming of the change so far, but it's in discussion. When we come to endoscopic accessories, we don't necessarily have the same evidence base in terms of a paper quantifying their environmental impact, but I think all endoscopists will be aware of the volume of the kit that we use. We and other groups are trying to establish this more definitively, and this is a picture on the left of us trying to disassemble and weigh the constituent parts of a biopsy forceps. And the process really involves weighing and establishing the constituent parts and cross-referencing to these databases that hold emissions factors related to the weight of certain materials. And once we have established more directly the footprints associated with these accessories, we can then try to target those accessories which have the greatest footprint and see if there are options for low carbon alternatives, and also find those areas where we most need to innovate to lessen the impact. Although this hasn't been published in endoscopy yet, other people, particularly the surgeons, have already started looking at it, and the anaesthetists as well. This is just an example of some urologists who have looked at using this technique to establish the footprint of the kit they use for prostate surgery. So the question is, how can we make our polypectomies greener? Well, I think it's reasonable to say that the environmental impact considerations are probably not going to be the primary driver for decision making in the approach or devices for polypectomy, but they could at least be a consideration and a point of further discussion. And so some sort of basic principles would potentially hold that using a cold snare versus hot snare approach would avoid the use of an electrical surgical unit and the disposable electrodes that would be required. Equally, underwater EMR would avoid the use of an injection needle and the syringe and solution. Accessories can be reused during a procedure, reusing biopsy forceps or snare, both within a procedure or the same patients requiring both an upper and GI endoscopy. There is a thought that probably we are overzealously using prophylactic clipping after polypectomy, and which, if unnecessary, would be also a possibly mitigatable environmental impact. And maybe this links closely in with the idea that we should be potentially closely auditing the accessories we use during endoscopy to see where variation in practice occurs. And finally, what do we do with this kit after use? Well, there are solutions out there, and I think Joao has talked very nicely on waste segregation. This is a type of sharps or disposal bin. We don't actually use this in our trust, but I'm aware of its existence, which takes single-use metallic devices, largely from the surgical environment, but also from endoscopy. And instead of then going for high temperature incineration, they can be sterilized and reprocessed in a metals processor plant. So there are options out there that certainly our unit would like to explore how beneficial this is and the implications. And I think in everyone's home nations, that will be the case too. So I will stop there. So I think about my time, obviously pass on my thanks to my supervisors during this year, Sian Thomas Gibson, Boo Hay, Nick Vudavudas, and Francis Mortimer, and I'll pass back to Enrique for any questions.
Thanks a lot, Robin. It was an excellent talk and many simple tips. I have a question, the first one about the biopsy pots. Why have we so large pots? Is there any reason for pathologies? Because it seems very simple to change it because our biopsy are very small. What is their answer about this? Do you have anyone?
It's a very good point. It's one of the first things I thought when I heard from Seb that they had been looking at these smaller pots, and it's one of these things. He would be better to answer that than myself, because you don't know whether it's just a quirk of the system and it's something that's cropped up for convenience factors along the way historically, where they were used for for some other form, that the same generic pot can be used in different contexts, or whether actually there is a very meaningful reason from a processing point of view. But it sounds like the fact that looks like they are able to shrink the size, that maybe the reason for the size at the moment isn't that operative.
Thank you.
Okay, Robin, and I have another question for you. I don't know if there is data for that, but which is greener, cold snare polypectomy or polypectomy with the biopsy forceps for diminutive polyps?
So I'm not aware of any comparative quantitative analysis of that. The only thing that we would have data on is the processing of that biopsy that is sent. you, broadly speaking, when you look at the actual accessories used in both instances, the weight and type of materials would give you some indication as to which of the devices themselves have a higher environmental footprint, but it's not always as straightforward as that, and you would have to know exactly the weights and what's inside each accessory. So I'd be guarded about giving you a comparative answer there, because it doesn't exist.
And one other question that is in line with a question that was made by Bas Beusten. Savary dilators are a very good option for dilation. How can make our dilation greener?
Sorry, Enrique, say that again. Is there a question on the?
Yeah, I'm now speaking not about polypectomy or biopsy, but about dilation. Could you give us any tips on how to make our dilations greener? Is the same using a Savary dilator than a balloon dilation, or even new devices that are being developed, such a cup? Could you comment on this?
Yeah, so I mean, similar answer as before, that I'm not aware of any published comparative data on that. So the only way you could approach it, broadly speaking, is look at any obvious differences between the two choices and processes and the materials involved. But no one's actually published any sort of quantitative publication of the two. So I'd be wary again of speaking with authority on any specific differences between the two.
Yeah, I think that we need to perform a lot of research in the future. Mathieu, do you have any other questions?
A small point. Do you have any idea of the differences between the different bowel preparation, like for example, degradability, this kind of things? Because PEG for me are not so easy to degrade after. Is there any difference? Do you want to work also on it? Because for me, it's something we don't know exactly, and what is really the impact of this bowel prep in our practice.
Yeah, so I'll give a slightly tangential answer to that. So I, like with all previous answers, I'm not aware of any published comparative study on that. All I would say is one of the benefits of life cycle assessment over other types of methodologies is looking at the environmental outputs that you can assess. And the reason that is important, as most of us in the lay public are very familiar with the greenhouse gas emissions related from a process. In life cycle assessment, you can also look at other environmental impacts such as biodiversity loss and the effects on the water systems and eutrophication. And the reason that's important is there may be some things that we use in the medical sector that have important environmental impacts that are not carbon mediated. So one hopes that with some of the more sophisticated analyses that can be done, like life cycle assessment, we could make sure that we look at the impacts of some of these things further down the environmental chain and not purely through their greenhouse gas emissions. But I'm not aware of anyone having done that yet, looking at bowel prep specifically.
Thank you, Emma.
Okay, thank you very much, Robin. Unfortunately, I think it's time to close the webinar. Fantastic talk, Heiko. Thank you, Joao. Fantastic, and Robin. See you soon. I hope that you join us in Dublin. The early bird registration deadline is at the end of February. There are a lot of good reasons to join ESGE, not only these webinars, you can also apply to a fellowship and to research grant, reduce registration fees for the days, involvement on guidelines, and so on. So please join us. And see you next week with the webinar about endoscopic management of upper GI neoplasia with the Korean Society of Gastrointestinal Endoscopy. I would like to close only by saying that probably, at least from my opinion, green endoscopy is not an option, it's the option, the only one that we need for the future. There are many things to do, but step by step, I think, or I feel, or I want to think that we are changing things. Thank you very much for being with us.